Good morning and welcome our new early arrivals to our Eggheads, our February session of the C-HI webinar called Eggheads. We'll get started in just a minute or two. Good morning. It's just about 8 o'clock. We'll leave a minute or two for other people to join our conversation here today, but welcome to C-HI's February Eggheads webinar. All right. As people are logging on and getting settled into their probably home office seats this morning, as it's so snowy outside, but we're hoping everybody gets their coffee. And while we're doing that, just to warm things up here a little bit, C-HI is on the lookout for the best coffee shop in the Denver metro area. So we'd like you to put into the chat what your favorite is. We're also improbably looking for the best donut shop in the Denver metro area. So if you could put into the chat both your favorite local coffee shop as well as your favorite donut shop. And if they're one and the same, that's even better. Let us know what you order there because we are on the lookout for the best places to go. Before we get started, I will just share with you a few housekeeping items. This presentation will look best and work best if you switch to speaker view in the upper right-hand corner of your screen. We'll also have time in this presentation for questions and some dialogue. So please share your questions in the Q&A at the bottom of your screen. And we'll track, that helps us track the questions that come in and make sure that we can answer as many as we possibly can. We may call on some of you to ask your questions live. And if we do that, we'll ask you to raise your hand so that we can unmute you and bring you up to speak with the panelists. Now that I have all of that out of the way, I'd take a minute to introduce myself. I'm Michelle Leek. I'm the president of the Colorado Health Institute. C-HI is an organization based on the belief that we believe in good health policy leads to a better and healthier Colorado. And every day it's our job to bring research, insight, and expertise to leaders across the state because informed decisions lead to better health for all. Eggheads is our way of coming together with others in the health policy community to share what's going on in our work and in our days. That's our goal. It's still Valentine's week, and I think it's fair to say that this month's topic is something that's near and dear to all of our hearts at C-HI, the Social Health Information Exchange. I'm excited for our team to share with you, and I also want to acknowledge that this topic is a key pillar of C-HI's 2022 health agenda. I'll be sharing more about that agenda in next month's Eggheads, but I'll tip my hand a little to share with you that integrating systems of care is a critical piece of our plan. We know that social, human, and health services that are integrated can improve the health outcomes far more than one siloed component. Yet our systems continue to be antiquated and fragmented. C-HI will play a significant role in integrating community-based services with medical care, and you'll hear more about our efforts this morning. And as we advance that work in the years ahead, it's critical that we begin speaking the same language, which is why we're all thinking of today's session as S-HIE 101. Your tour guides on this trip will be C-HI's resident experts, my close colleagues, Karam Ahmad and Kirsty Clavercamp. And we're thrilled to have them joined by Stephanie Puglisi, who is our newly minted director at the Office of eHealth Innovation. Stephanie, congratulations on that. Kudos to you for your appointment and promotion to the director position. And I'll turn it over to you right now. Thanks.
Thank you so much, Michelle. Really glad to be with you all today. Quick reminder what S-HIE is, for those of you who weren't with us last time to hear about the latest. The Office of eHealth Innovation is a program located in the Lieutenant Governor's office, and we work closely with Medicaid, state agencies, as well as community partners on a variety of health IT initiatives. Today, really excited to be with you to talk about Social Health Information Exchange. We've partnered closely with Colorado Health Institute, as well as many partners in this space to really try to move the needle forward in Colorado. And our vision is really a flexible and interoperable infrastructure that is vendor agnostic to support whole person care. And I think we're ready for the next slide. Thank you. So S-HIE, in partnership with C-HI, published this brief a little over 1 year ago. What a year it's been, as a step toward developing this interoperable and flexible infrastructure. And the goal for that is really to support coordinated whole person care across physical, social, and behavioral health domains. This brief updates and builds upon the work that was started by a group of governmental, healthcare, public health, philanthropic, and community-based partners in 2018. And it really reiterates the need for core components for S-HIE infrastructure and highlights key considerations for governance, as well as system implementation and user adoption. Interoperability is key to this work. That's one of our big buzzwords, but also just truly at the core of this. And we at S-HIE in the state recognize that there's an abundance of systems within and between providers and organizations throughout the state that are already in use. And so our current social health information exchange projects support technical solutions that share core components, data standards, and common practices for the meaningful exchange of social and health information. This will allow providers to use the tools that are most useful in supporting their patients while still exchanging relevant data across health and social systems. It really underscores the intention of statewide partners and stakeholders to create a S-HIE or SHIE ecosystem that effectively supports a coordinated system of care for Coloradans. And S-HIE is proud to have sponsored the creation of this resource, as well as several current and planned projects across the state to start implementing this vision. This data-driven infrastructure will reduce provider burden and promote efficiencies across systems, paving the way for improvements in health equity. The timing for this work is key, as we're working with our state and community partners to align on a statewide solution. We will maximize the technology we already have and plan for sustainability along the way. And a little teaser, we hope you'll join us at the June Eggheads webinar to learn more about those projects. Until then, I'll hand it off to Karam to walk us through the key takeaways from this document.
Thanks, Stephanie. So really the basic idea for social health information exchange, which can, it can get technical at times, but sort of at the core of it is something very clear and very significant. As Michelle and Stephanie have alluded to, it's really about building a community of care around individuals and families. So we know a person's life can affect more than the medical care they receive. So housing, food, where they work, where they play, where they go to school. You see that represented in some of the bubbles on the screen. Many people are familiar with the social determinants of health graphic, where like 80% of the person, like the icon, is filled up. This is really like a way, S-HIE is really a way to address that. So the problem currently is that the systems that support people's health, social, and economic needs are fragmented. This includes what you see again in the bubbles on the screen: food assistance, housing and utilities, transportation, healthcare, and among other services. So an interoperable S-HIE ecosystem takes those fragmented but essential services and supports and creates really the connections to strengthen coordination among not just human and health services, but also community-based service providers like food pantries, for example, to offer more comprehensive and customized care for families and individuals. So let's really break down what the key functions of social health information exchange are. And we've broken it down into 6 pieces. So let's walk through these key functions. First is what we call screening protocol. You have to have a protocol for how screening of patients and clients are done. That means making sure that all healthcare and community service providers have a standard way of screening patients and clients for services like food, housing, utilities, connecting people to behavioral health resources, for example. So that's the first one. Second is a resource inventory. You create a resource inventory for community-based social services. The purpose is really to provide an up-to-date sort of repository of information about the organizations that provide these services. So, users of the Social Health Information Exchange know what resources are available and where to refer people. And if people are interested, they should be able to also access that information. Third is what we call pathways to the resource inventory. So you want to make sure that the resource inventory is usable for the public and for the providers, the people that are doing the screening. So a useful resource inventory is made, of course, available to all of the users, and the users should be able to look up and retrieve the information that they need. It should be as simple as that, whether it's a case manager or a doctor or anyone. And fourth, the users of a social health information exchange, they should have the ability to manage referrals for their clients, whether it's on social, behavioral, or physical needs. So, having a unidirectional referral system, it basically means that it should be set up so that partners, the people that are using this, can screen and refer their clients to one another after they screen their patients and clients. And then building on that, and this is really a key component, is having a bidirectional referral system, which simply is sort of having not just referring clients and patients to services, but having the ability to determine whether a service was received and whether it really met the needs of the individual. And then finally, in time, as data are being collected and shared, among the users of the Social Health Information Exchange, a significant benefit of this effort is really creating the capacity to share data between groups to support care coordination and population planning and assessment. Having sort of, imagine knowing what your community's most pressing needs are and whether the systems that are set up are meeting them. So having population health analytical abilities allow for data-driven decision-making. So all of these components really together will benefit the partners you see at the bottom of the screen. This includes case managers and people who are working at the county level, healthcare organizations, care coordinators and managers, the public, patients, families, and clients, and of course, the community-based service providers that I alluded to earlier. So how is this coordination of all of these efforts, how is this organized? And the way we think about this is, to create a more coordinated S-HIE ecosystem in Colorado, there are really 3 tracks of work that have to occur iteratively. And first is system implementation, which you see up on the right side of the screen, upper right. Implementation is to ensure that alignment of strategies across the regions of our state for implementing, sustaining, or adopting these systems and technologies are scalable, they're efficient, and they're user-friendly. That's really central to this. So it's really the decisions behind the technical elements. Second is user engagement and adoption. So the work must be done to ensure that the S-HIE meets the needs of its eventual users. These are, decisions on user experience and value to the people that we want this work to help. And then governance, of course, is central to this work. And you'll see that at the bottom of the screen. And governance, of course, is needed to ensure that there's really an equitable structure for making decisions about and for funding S-HIE efforts. So, sort of a note on governance versus information governance. So when we're talking about governance, we're not only talking about information governance. Governance is really a broad term that encompasses kind of all the decisions that the group must make together, and info governance is kind of a subset of that. So, governance on the whole includes other decisions like in how you do engagement with the community, how this work is going to be funded, and as well as information governance. So really the next slide has a framework for some best practices that we put together represented in what we would call successful governance of this work. So you see the acronym BRIDGE, which in a coy way sort of represents the whole point of this work. Governance, we recommend sort of the following key elements. First is to build a shared vision. You want to make sure that the partners in S-HIE work are building shared visions, sort of have a common language. They're working together for the same goals. Second is to rally community partners and cross-sector partners, making sure that the priorities that everyone who's bought into this work really are shared, and that is done through facilitated discussions. Third is really identifying cross-sector use cases. And what that means is, finding ways to, represent and best address a community's unique priorities with some use cases that are timely and relevant to the community. And then developing roles and responsibilities, of course, is important to this work. It's important to be very clear among the partners who is doing what and when, and at what level of power. And then, of course, gaining buy-in, whether it's from the community who will benefit from this work, the clinical partners or the funders, or any of the other partners, really making sure that not just the interest is bought in, but there's also buy-in in terms of resources that can back this work, which leads to really ensuring that there's sustainability through collaborative funding pathways. happen if it is sustained and resourced. So together, this sort of bridge framework for establishing governance helps connect all of these initiatives at the state, regional, and local level. And then finally, this is my last slide, but there are a lot of efforts in progress. The work is already underway with dozens of partners across the state, from the San Luis Valley to the metro area. You'll see that represented with county agencies, health systems, and so on. But the point I really want to make here is these individual groups are tackling this work right now across the state. And the next section, which my colleague Kirsty is about to jump in on, is about the interoperability between these groups and how we get them all to work together. So now that you know how S-HIE kind of works, my colleague Kirsty is going to share why it matters and how these groups will work together to advance the health of Coloradans.
Thank you, Karam. Good morning, everyone. Thanks for joining us today. And a shout out to Stephanie and Karam for giving us a really great background to understand the context of why we're here today. As you heard from them, there are so many different efforts related to social health information exchange that are happening across Colorado, at the state level, at the regional and local level. And so what we're here to talk about today is the value of connecting all of those existing efforts and systems. And we think that message is key here. It's guided us so far and will guide us into the future. And so with that, we are guided by this shared mission that we worked to develop last year with our partners that says, we are here to collaborate and align technology, connecting community resources and the people they serve. You'll notice here that we're not talking anywhere about developing a new platform, a new system, or a new way to coordinate care. What we really are trying to do here is to align ourselves in partnership and via interoperable technology to create this larger S-HIE ecosystem that we can all work collaboratively within. And when I talk about our shared mission, this is not just Colorado Health Institute alone. We are honored and privileged to be a convener and facilitator of this work, but we really couldn't do it without the leadership of all of these partners across the sectors you see on your screen here. Right now, we have over 30 different active partners from not only local public health and healthcare systems, but also community-based organizations, human services, regional accountable entities, and of course, the heart of the work, community members themselves. And so when we say we here, we really are talking the big we, this huge partnership under Metro Denver Partnership for Health that we're working toward regionally and also staying closely connected with Stephanie and her team at the state level. Next slide, please. So while we are guided by this mission, that was definitely curated from experience across the partners of their organizations, listening to the challenges, right? And the goal of better serving Coloradans, we felt like we needed to take a pause and make sure that we were grounded in community before even moving further forward with this mission. And what we did by that is really intentionally putting people at the center last year when we worked with the founding S-HIE steering committee under Metro Denver Partnership for Health, and with them worked to find a very clear value proposition for building this interoperable S-HIE ecosystem. And to do that, we not only worked with the partners I mentioned previously, but we also hosted a series of focus groups of people who are on the front lines every day, working as care coordinators, case managers, navigators, working with Coloradans to get them better connected to health and community-based services. We also talk with leaders across community-based organizations, as well as the other sectors that we called out. And most importantly, we also spoke with community members last year to hear from their lived experience, their challenges and successes of navigating our current systems and how they feel like we could do a better job moving forward to connect them. So all of that to say is through those conversations, we worked to define a very clear value proposition for this ecosystem. And what came out of it was 3 pillars of the value of connecting all these different efforts. The first is that an interoperable S-HIE ecosystem emphasizes people over process. The second is that it finds the fit for whole person and whole family care. And lastly, it builds a stronger safety net. So what do these words actually mean to the people that we talked to last year? Well, let's dive a little deeper to call that out. First and foremost, interoperable ecosystem emphasizes people over process. And what that means, from what we heard, is that it does this by reducing administrative burden, by providing one point of entry for providers to work within, so that they can use the system that works best for their organization and serving the individuals and families they're caring for every day. So to break this down a little further, this means that even though I may be working within my own system, I'm connected to all of my other partners' systems via this interoperable network. This allows me to save time, responding to emails, reaching out to colleagues, trying to find the right resources, and collecting duplicative information from the individuals and families we're working with. We have one point of entry. I don't have to log into multiple systems, yet I'm connected to all the other partners within this ecosystem. And by lessening the time we have to spend on all those administrative duties, what we heard is we can really spend more attention on families and the people that we're serving. And in turn, all of those individuals and families can spend less time repeating their stories over and over because we're connected and we're walking with them through their experience and getting them connected to the services and resources they're looking for more efficiently. So it's not just getting people connected to the services we have, right? It's being able to provide them with the option to find the fit for whole person and whole family care. And this is what we heard in terms of the second pillar of the value of this ecosystem, that this ecosystem would allow users to be more confident that they're accessing a complete array of options to meet the unique needs of individuals and families. So we're not just offering the resources that we're aware of, but we're actually able to tap into the resources that our partners have in their own inventories and actually provide options for individuals and families to choose what's best for them, finding the right fit for them. And this allows us to provide more tailored care and really make a greater impact in their health and overall well-being. Last, but certainly not least, what we heard is that this ecosystem will build a stronger safety net by better addressing community priorities in the near term, but also the long term. And what we mean by this is when we're working in this larger ecosystem, we can be more sure that we have reliable and up-to-date information within the health and community-based human service systems about what programs and services are out there. Get people more seamlessly connected to those services and resources, while also using this ecosystem to be able to better collect and monitor where there are gaps, where we don't have enough services, where there are capacity issues, so that collectively we can do a better job of targeted investments moving forward. Right, and a lot of this work is already happening individually across sectors and partners, but we believe the impact grows exponentially when we're doing this collectively within the ecosystem. All right, so we really do believe that those three pillars that I called out well represent what we heard in all of these conversations about the value of an interoperable ecosystem. And with that said, we always feel like direct words from community members have real power. And so that's why we want to share direct quotes from you here and on the next slide in just a moment to hear directly from their stories, from the experiences that we heard. Because what we heard over and over again is it can be challenging to find the right resources at the right time. So how do they believe that this ecosystem will better serve them moving forward and allow them to access the care and services they want? One of the community members we heard from said, my care coordinator helped me oversee all my other care coordinators. A huge job, right? She kept track of our overall plan. But then when it came down to it, this person had to sign 18 different forms just so the one care coordinator could talk directly with all the other care coordinators. Huge burden, right? Huge administrative burden on everyone involved. If they were all working within this ecosystem with the right agreements, policies in place, that would offer a much more streamlined way for them to coordinate care and work with that community member. Another member said, filling out applications are terrible, downright terrible. You have to be diligent. Within 9 months of starting the PATH program, they were able to find 8 different choices for housing. But why did no one tell me about that program before, they said. It's very complicated to sign up, where a referral within the system or ecosystem would it have been more helpful. So that well-intentioned care coordinator wouldn't have missed out on that program that really best served that person. All right. This is probably one of my favorite quotations. I promise you, we did not plant this. This was really affirming for us to hear from a particular community member who really said, I believe this ecosystem will help us address community challenges and priorities. They said, I read the S-HIE white paper, the one that we previously talked about this morning. You have it down, they said. We just need to make it happen. I can see it. It would save and transform lives. Now, I don't know if that gives you goosebumps, but it does for me at 8 o'clock on a Thursday morning, because it really is what grounds us moving forward when it gets hard, figure out how we're going to do this, but we believe it's possible. We have a lot of hearts and minds working on it across the partnership, and we keep these community stories front and center to remind us why we're doing this work and why it will be possible moving forward. So thank you. And now I will pass it over to my colleague. We left a fair amount of time to hear from you out there listening to us. We'd love to have conversation with you and answer any questions you might have.
All right, we do have a couple of questions showing up in the Q&A. David Keller, if you can raise your hand, hit the little button down on the bottom right hand of your screen, we will unmute you because we'd love for this to be a conversation. You have 2 very good questions. I think Kirsty alluded to some of it, but there's...
Well, yeah, thanks. Well, first, thanks for that. As I wrote when I sent the questions, I started typing right at the beginning because I'm a really slow typist. And wanted to get these in. I guess I just wanted to start, I'll start with the first question I put in, which is in sort of stating the vision for this. The term person-centered care got used, but throughout the presentation, you kept referring to person and family-centered care. As a pediatrician, I appreciate that because I can't take care of a child without taking care of the family. But I'm wondering why, I'm wondering why that isn't included in the vision, because I do worry periodically that we tend to get focused on the individual and forget that all of the service delivery, no matter what we're doing, is happening in the context of family. I actually like family-centered care better than person-centered care.
Thanks for the question, David. And I just saw your second one in the chat. So I think Carmen and I can work together on this. I can address your first question. If we have time, we can go to your second. I think the simple answer is, David, that we're learning and growing with our partners along the way. And when we originally coined whole person care, I think we really felt thinking through the whole person individually. And then it was our partners and listening through those community conversations that said, wait, we also need to think even more holistically than whole person, because many people live within the context of families, right? Especially when we're talking about people of all ages, not just children, but also older adults. And so I would say that really through experience and learning and thinking more critically about the work that we were doing and getting better at defining the value moving forward, that's when we started adopting that whole person, whole family centered language. And to be honest, we just haven't necessarily gone back to that original mission that we wrote, but definitely now as we move forward, we make sure that sort of language and intention is front and center. I hope I answered your question adequately. If not, feel free to let me know and I can go further before we pass it over.
You did a fine job. That's more or less what I suspected, but I kind of wanted to remind you that I think that's critically important. I would argue that even a person who's living by themselves is in a family of one, and there's very few people who actually are, be it ever as functional or dysfunctional as you'd like.
Thank you, David. Do you have
Yeah.
access to David's second question? Otherwise I can call it out.
Yeah. So David's second question was, why stop at bidirectional care? Should the goal be collaborative care? And Ashley actually started to answer this question in the chat as well. But yeah, of course, collaborative care is the ultimate goal. You want to make sure that I think the one point that is important to make is that, one, this work is going to take time, right? And in order for it to be successful, we want to make sure that first the unidirectional and the bidirectional referral systems are set up. Just to allude to Ashley's comment, like these are stepping stones to the path of really making that care more collaborative. So Dr. Keller, your point is well taken, and it resonates with really how we're thinking about this work as well.
I'm going to jump in, excuse me, I'm going to jump in here real quickly because Nancy has had her hand up for a little while to ask a question. Nancy, can you, if your hand is no longer up, can you raise it again so we can unmute you, and then we'll start getting to these others showing up in the Q&A. Nancy, are you still there? All right, we can come back to Nancy, maybe message us if, or raise your hand again. In the meantime, got a question here from Tamara Keeney. Kirsty and Karam, can you see these questions, or do you want me to go ahead and read it?
Yeah, we can. I'm happy
Great,
to start.
okay.
And I know Ashley looks like she's also typing an answer, so Tamara will hit it from both sides. So Tamara's question is, can you talk more about screening tools? Is there a vision to come up with a standard set of accepted screeners? So this is a multifaceted question. Here at Colorado Health Institute, we're not here to necessarily institute one standardized screening. We really feel like that decision is the responsibility of the partners who are actually using the screenings day in and day out, and know which of those and which assessments work best for the individuals and families that they're working with. With that said, though, within this interoperable ecosystem, we're thinking about standardized almost domains that we can screen for, which Karam called out, right? It's maybe some of the highest social needs that we're working with: food security, housing, transportation, et cetera. So that regardless of the screening tools that individual providers may be using within their own organizations or systems, we can at least transfer and communicate the results of those screenings across the ecosystem so that we can collectively know which individuals and families have which needs, maybe which of them have already been addressed and which we still have to work on. So as far as a vision for a standard set of screenings, yes, I think we're hoping at least in some way we can come to terms, right, with some maybe best practice screenings, but in no way will we tell our partners, which to use. We really feel like they know best how to work with the individuals and families they're serving. But there's definitely a standardized data component to it to make that all work behind the scenes. And I just saw Karam come off mute, so I'm going to pause here if Karam wants to add.
Yeah, and to Kirsty, Tamara, there is we actually put together with S-HIE last year on that. So on that link with the S-HIE white paper, we also put together a screening implementation guidance document, and this is really geared towards providers to instill those best practices that Kirsty was alluding to. As well as a list of some of the most reputable screening tools that are available. So if you're interested, I can send you the link.
And then I think I might jump in here. I see Lisa Jansen Thompson's question. For the rest of you, Lisa asked us, are you finding communities choosing just one platform successfully, or still finding multiple platforms being used with future hopes of interoperability? Some communities have chosen one platform, and when I say that, we can point to communities nationally, but also here locally in Colorado. Locally, right on the western slope, we have Quality Health Network, and they have a particular platform that's worked really well for their communities. Here in the Denver metro area, as we're working for Metro Denver Partnership for Health, we're finding that our partners are most likely going to be on a variety of different platforms. And so with that reality in mind, that promotes choice and further really enhances the value of thinking through this interoperable ecosystem, using the interoperable technology that are out there to connect all those systems, because it is very unlikely, right, that moving forward we'll be on one system or platform. They all provide slightly different services, right, and benefits to different partners. And so that's why we're here to really figure out how to connect them all into this larger ecosystem.
Karim and Kirsty, this is Michelle. Hi, thank you for the overview. Sometimes it's easy to think of S-HIE work as being like mom and apple pie, and like it all makes sense. Why is this work so hard? What's challenging about this work?
I can start, and Kirsty, you want to tag on? There are many things that make this work hard, and I think it's central to the success of this work to sort of answer your question on what makes it hard. Is what would make it successful is making sure that all of the entities that are making their own individual decisions that are right for their community, that are right with the systems that they have, that are right with the needs that their community have, ensuring that power can be shared at different levels. So I think the greatest challenge is coordinating all of the people that are included in this work and ensuring that the best outcome for the community, for the individuals and families, is represented in a way where people's best interests come forward. So it's about coordinating people, it's about coordinating systems. It's challenging to coordinate people and systems and make everyone happy and make all of it work. The technology is there. It's not really about the technology being difficult, because there are ways to do this, right? With the technology, a million different platforms, but getting the work, getting buy-in and getting people to agree and govern this work in a way that works for everyone, and then sustaining it, I would say, is another challenge. Kirsty, do you want to tag on to that?
I was going to, Karim, but I think you said it beautifully. I think the only thing I would add is say this, at the heart of it, this is systems level work. And so it means it's time intensive and takes a lot of effort and strategy to align everything that Karim called out. Not only the governance, but keeping community priorities at the center. And then the technology will follow suit, right? But it's really the former that take the most time and intention to figure out. And then we can tell technology, right, how we want it to work for us in our communities.
Right.
Thanks for the question, Michelle.
Yeah. So if I'm understanding, this seems more of a people or family challenge, right, than a technology challenge. Do I have that correct in the assessment?
I would say yes, Michelle. And I think the reality is our partners are coming together because they have this shared mission and vision.
Right.
And with our current systems, a lot of what we're doing is in silos because of our current funding streams, for example, right? So it's thinking really creatively now how we can use the funds that we have to start this collaboration, get this ecosystem started, and then as Karim alluded, think through how to change how we blend and braid our funding streams in the long term to support the partnerships that are driving this and the relationships, and then maintaining the technology. So yes,
Yeah.
it's really about the relationships and partners and figuring out how to sustain those.
Yeah. I see a close colleague, Jason Greer. I see that you're active on chat, and I just wonder if you'd like to enter the conversation, because I think you have some really interesting points about the challenges around policy and governance. Jason, are you there and willing to come off mute?
Jason, it might help us if you click raise your hand. This way we can unmute you. Oh, he's got to dial in. It sounds like
Okay.
Jason is just in on chat right now.
Gotcha.
Jason, when you're ready, we warmly welcome you. Like I said earlier, we can't do this work without the partners. But while you're dialing in, I'm wondering if we can address another question, Karam. Jenny asked us, what have you seen in regards to individuals opting into these exchanges? I'm concerned our clients will not want to participate very often, which will limit the benefit of the exchange. I think I'm going to try and answer this question twofold. I think clients could mean providers and clients could also mean community members. So in thinking through providers, I would say, Jenny, more often than not, we're having providers in the community reach out to us to say, this sounds awesome. We want to learn more about it. How can we plug into it? Because they really do struggle with everything that we've talked about today in terms of this value proposition. Duplicative resource directories, the administrative burden, trying to manage multiple systems, really being able to effectively and efficiently walk with individuals and families. They like this idea of actually being plugged in to this larger network. That does not go without saying, right? We have to think through the necessary policies, data sharing agreements, privacy, et cetera. But putting that aside, really, I feel like we've had more providers than not come to us to say, we want to figure out how to be a part of this moving forward. From the client side, oh, thanks, Jenny. I just saw your clarification. I'm asking more about clients. I work with the co-responder program, and many clients have not always had great experiences with different partners. That's really interesting, Jenny. I think I would ask to connect offline, because when we've had our community conversations so far, I think the sentiment has been from those community members that they're really interested and want to make this happen faster than I think we can actually make it happen. But we are bound and determined to make it happen. So I would say we'd love to talk with you offline, because we always want to make sure that we're hearing from those who maybe have concerns, so we can take those into perspective as we're building this moving forward. Karam, do you want to add to that?
The only thing I would add generally is it is of the utmost importance that this coordinated S-HIE ecosystem is set up in a way that prioritizes the interests of individuals and families. That's sort of a general statement, but in any sort of effort like this, you want to make sure that there's a that you really do prioritize the individuals and families, and that it's not a system set up to benefit the system itself. You know, there are benefits to the system, of course. And when I say the system, I mean the providers, I mean the healthcare system, I mean the care coordinators. Of course, there's the benefit of collecting data and being able to do better population health planning and allocation of resources and all of that. But what matters is the health and well-being of people, and a system must be set up for people to have great experiences with those they're interacting with, Jenny. So I hear you, like that is, I mean, that is literally what matters most, is the experience of the clients and patients.
I believe Jason is online and ready to go. Jason.
Hi, good morning. Can you hear me okay?
We can.
Great, thank you. Hey, thanks for letting me jump in. And Michelle, great question. And Karam, I really appreciated your answer. I think what I'm responding to is, why is this difficult? Maybe a little bit more about Michelle's question. And so I think it's difficult for all the reasons that the C-HI team has laid out, that there are technology challenges. We've got great technology tools that are out there. All the referral tools, the care coordination tools, the HIEs, all that stuff works really well. But we do have a very siloed system where social services and healthcare and criminal justice and even behavioral health all tends to be kind of in its own kind of separate component, and the people that we serve, live inside all of those. And so figuring out how to sit between all of those systems, I think, is one of the biggest challenges. To Kirsty's point about, creating blended funding and blended systems, and interoperability between those systems is also a challenge. I think the legal aspects of data sharing and protecting person privacy, but also protecting organization privacy is a big deal. It needs to be kind of navigated at the same time. Colorado, to our benefit, is not a state that mandates use of individual tools. We allow for choice, which is great, but that creates a model that requires a lot of integrations so that we can make those individual choices work together really well. And then there's the funding that has to go out to community organizations to build up their capacity and have them really align this work with their businesses, and so we can start to make improvements together. And then my last point, I guess, would be that once you kind of do all of that policy and integration and governance work, then and only from there can we then point all that towards public health improvements and really focusing on person experience and disparities and the costs of care and all the things that we care about. And so I think that's probably the biggest thing, is it's just the vision, the integration, and the work and the funding, the policy and governance that goes with it. But we're on the right track. We've made a lot of progress, and thanks to C.H.I.'s leadership inside this space, I feel like we're getting really close at this point. So thanks for letting me jump in and say hello.
Great.
Thank you. I want to call the panelists' attention to a question from Priscilla in the chat. She's asking, could you tell more about the work done on the resource inventory? Who will provide the organizational structure for this work? Can you talk about that a little?
Thanks for that question, Priscilla. And everything that we're doing, we're trying to leverage the existing infrastructure that's out there. So we're not here to develop a new resource inventory. I would say we're still working with our partners to figure out who can take a lead on the centralized resource inventory, right, that we're envisioning here. But I think most importantly here, the idea is to leverage the existing resource directories that are out there and then connect them all into this more centralized one that everyone can tap into. And like I said, we're still working with our partners to figure out who can take a lead on that, because we're all definitely taking lead roles in different ways as we're building this ecosystem.
At the risk of dating myself more than my gray hair already does, some of this conversation reminds me of dialogue we had, I don't know, 5 or 10 years ago about wellness programs, and specifically like, where does the benefit accrue within the system? I've noticed a few questions in the Q&A and chat about the financing and funding, and I can't help but think that the value proposition and the funding are linked. How are we thinking about where benefit accrues and who should, the financing of this? Stephanie, I know that you give this a lot of thought at the Office of eHealth Innovation. So I invite you to be a part of this conversation as well, because I think this is, again, another sort of fundamental challenge of S-HIE work.
Absolutely, Michelle. And I think this is another one of those big challenges, is thinking through, again, how do we involve and support our community and providers without then placing an additional financial burden on them. And so from our perspective, from the state side particularly, we're really thinking through how do we combine different funding sources and really braid them together to support that statewide solution, at least to get this up and going and off the ground, and then thinking through, again, how do we share that going forward. But as far as the build of it, it really is thinking through the federal and state resources that we have right now, especially, for folks paying attention to federal legislation and funding, there's some big opportunities out there. So really wanting to maximize that for this initial build.
Great.
Michelle, I think it's a really important question that we could spend all day talking about. And it's one that we reflect on frequently, I would say, as a team. And right now, I hope it's okay, but I really want to pass it off to Carm and my colleague S-HIE Brown, because she's been a lead, right, of this team. And I think this would be a really great time to bring her voice into the conversation to also address that question.
Hi everyone, S-HIE Brown, one of the directors here at CHI, and funding this type of work is my personal passion project. So if you know me, you probably have heard me talk about this before. But I think that there are many different things to fund here. Stephanie talked a little bit about that technical build and how do we get that shared infrastructure in place. There's also the question of how do we fund the services that we're referring to? And we are facing an impending crisis of our social services are underfunded both at the government level and also in community. And if this system is successful, it's going to lay bare that deficiency. So that's something that we are thinking about now. It's something that we've been talking with our community partners about, thinking through what is your capacity to take additional referrals, serve additional individuals and families, and what would it take to get you there? One of the benefits of social health information exchange is that it can provide us some data to really get specific about the resources that are needed to fund this ecosystem of care. But there is still a lot of work to do there, and it's going to take all of us. It's going to take government funding, it's going to take private funding, it's going to take philanthropic dollars, and we're working very actively on how to pull all of these things together into sort of a braided funding stream in the short term, but also looking at alternative payment models and different funding mechanisms that are more sustainable long term, because we know that if we don't build sort of the ecosystem, including technical, including resources, including the people that are required to make this all work, then all of this investment that we're making right now is going to go to waste, and we don't want to see that happen.
All right.
I like to know what your personal passion project is, S-HIE. That's helpful to know here this morning. So I appreciate it.
We probably have time for one more question, and I see David has his hand raised. David, I think you're unmuted. All right, not hearing from David, although I do see a question in the chat from David. Are there mechanisms to define family in the context of this shared resource?
Okay, sorry, I lost the unmute button. You had to give it back to me. It just suddenly appeared. One of the challenges, most of my experiences is with electronic health records within the healthcare system. But even there, we have great difficulty in defining family and looking at linkages, and particularly when you're talking about, when I get a phone call from a family wanting COVID tests for 3 children, I have to go into 3 separate charts and order 3 separate COVID tests, and I have to type the same thing over and over again to do that, because we don't have a way of saying order COVID tests for this entire family. I'm wondering if within the S-HIE, you've developed any good ways of linking folks so that we know what is the family unit within the S-HIE, and has there been any progress made in that?
I can start answering your question. Thank you again for raising this. I would say last year we were in the very initial stages thinking through some of this, what I would call technical implementation to your question, like thinking through exactly what are the functionalities we want within this ecosystem, how do we organize, right, people's information. So I would say, David, we don't have an answer to that yet, but it's definitely been raised before with the exact same experience. No, I think it's important that these challenges keep getting raised, right? So they aren't forgotten. And so we're going to be kind of taking that initial input from last year, including the concern or issue that you just raised. And this year, really thinking through trying to hone in on specific use cases to start tackling some of those questions and thinking through, what are those functionalities, for example, the one that you just called out that we want to have within this. And then in that, right, it's working with the partners individually within their own systems to make it possible across the ecosystem. So I would say no answer yet, but it's definitely something we're thinking through, right, as a really strong functionality moving forward to help with that coordination. I hope I answered your question. Thank you for raising it.
All right, thank you all. And thank you for the great discussion. Really appreciate it. Ashley, Karam, or Kirsty, would one of you like to talk a little bit about our June Eggheads? But before we do that, I just want to flag, Michelle did also mention that our March Eggheads, we're going to be taking a look at the Colorado Health Institute's health agenda, of which we've got 3 pillars, and this topic is one of them. And we'll also be taking a deep dive into some of the behavioral health work we'll be doing. So watch for an email with an opportunity to sign up for that. But who would like to talk about June's Eggheads? Because we're already thinking ahead. All right, well, I can go. Oh, Kirsty, it looks like you're about to.
Thanks, Christy. I think this calls it out well here, and I think this has been a theme throughout this morning's webinar, is this is collective work. We do this with our partners, and when we say all of this is about connecting existing efforts, programs, and partnerships, this subsequent webinar that will be joining you this summer is really bringing forward those partners, like Colorado Community Managed Care Network that Jason Greer is a part of and spoke to today. So you can actually hear from our partners collectively about the progress we're going to make between now and then the plans we'll have ready at that point. So really it will just be part 2. We give you a really great primer of the work that's been done so far, the vision, and next time you'll be able to hear more from our partners who are a part of this and their role in it all.
We will be sending everybody an email. Not only will it include links to register for next month's Eggheads, but all of the links that we talked about and all of the links that we shared today in the chat, we will include those in the email as well. And it's 9 o'clock, everybody. Enjoy your snowy day and stay warm. Thank you so much for joining us.